So we've spent a lot of our conversation talking about first-line metastatic triple negative without PD-L1 positivity or patients ineligible for immune checkpoint inhibitors, which at the end of the day is most of the patients in this space, right? But for the proportion of patients, about 40% or so, that at least would have PD-L1 positive, whether or not they've received immune checkpoint inhibition in the past is sort of a separate conversation. But what do you do for those patients? That data is actually relatively newer also within the last year.
Sure. Yeah, I would definitely do the combination. If I have a PD-L1 positive patients, I would definitely do ADC in combination with Pembrolizumab. So I would definitely grab on that option because we do have some data and approval. So unless there's a challenge from payer, I would like to give that combination, first line.
Yeah, so Sacituzumab, Govitecan with Pembrolizumab from the ASCENT-04 study.
Yes.
And actually, so this whole first-line space kind of rounded out in 2025, 2026 with all of these studies coming to their at least initial data readouts. And maturity will come, right? I think we'll learn a little bit more about how durable these responses are. But in terms of, I think coming back to that point about patients who may be PD-L1 inhibitor ineligible, could we, other than PD-L1 negative and maybe like active autoimmune conditions, are there other patients that you would say shouldn't receive a checkpoint inhibitor where maybe you'd be thinking about single antibody drug conjugate therapy?
I think you've hit the two major ones.
Those are the big
that
ones.
My major ineligibility criteria.
Yeah.
I wouldn't say age. I've had plenty of patients who are elderly have good responses with immunotherapy, so I don't think age or fitness is one of them. I think patient preference should be factored in. Talking about IRA or immune-related adverse events, talking about how it can hit any part of the body can be daunting to some patients, and sometimes irreversible. And we've with KEYNOTE-522 and other types of regimens, dealing a lot with thyroid conditions, and so some patients may shy away from the just myriad of possible, though rare, when they accumulate, can be present in a substantial proportion of patients.
Yeah, it's a daunting informed consent conversation to have in many ways. That we're not as worried about many of these toxicities, but I think when patients hear it, it can be perceived in a very different light. And I guess the converse, I think I know your answers to this question, but we should put it out anyway. Are there any patients that you would still consider for first-line standard old cytotoxic chemotherapy and not an antibody drug conjugate in this first-line metastatic triple-negative space?
I think in the de novo setting, you're dealing with a lot of patients that you're not catching them when they've got a couple of bone mets maybe caught incidentally. I think I'm catching those patients when they're symptomatic from weight loss, from elevated LFTs, from hepatic burden. And so those are the patients where I'm worried about, and I'm reaching for an ADC in the first line, reaching for my first line, in the hormone positive, HER2 negative space. If you have those kind of things and you've got options and you're like, well, I can be a little bit more gentle with those first rounds of treatment, I do not view that triple negative breast cancer in the same sense at all.
Yeah, you'd be worried about the disease turning on you quickly, right? If you found yourself fortunate enough to see limited volume of disease, it's probably not going to stay that way for too long.
No.
Yeah. So it sounds like we're all aligned.
Yes.
ADC first is the right thing to do. Yeah, I completely agree with that.